We had part one last month. If you remember, we had Dr. Hammond, a pediatric neurologist from CAF, and also Dr. Alvin Ndodo, another pediatric neurologist from South Africa, and they helped us go through pediatric strokes. I'll give you a summary of what they said. For part two, we're going to have a pediatric hematologist oncologist. I'll introduce her shortly, who's going to talk about that aspect of strokes that has to do with hemonc. We are also going to have a pediatric neurosurgeon to give us an overview of how neurosurgery comes into play in pediatric strokes. And then Ms. Kukwa is a neuropsychologist who will also tell us about some of the cognitive testing and some of the learning differences that we'll see in children who have had strokes. So before we start, let me first give you a short overview of what we learned last month. So the key points were one, that stroke is a focal neurological deficit which is vascular in origin. It may either be ischemic or hemorrhagic. Common causes in children include sickle cell disease, vascular lesions, hypercoagulable states, infectious conditions, arterial dissection, trauma, metastatic lesions, and then Moya-Moya syndrome. The preferred neuroimaging modality is an MRI with a stroke protocol. However, if an MRI is not available, a CT scan of the brain should be done. For hyperacute management in adults, they usually will employ thrombolysis. However, this is not well established in children. What we can do immediately are called neuroprotective measures, and this include correction of hypoglycemia, hypothermia, hypoxia, anemia, and electrolyte imbalances. I remember the phrase, time is brain. So when it comes to pediatric strokes, all these hyperacute managements have to be done on time, because if you waste time, that's brain going away. Surgical evacuation is recommended if the cause is a hematoma. Medical management includes treatments for the underlying cause and sometimes long-term aspirin, depending on the cause. Surgical revascularization should be considered if the cause is Moya-Moya syndrome. So I hope this has given you a short summary of what we did last month. And now let's delve into the part two of the buffet. And let me introduce our panelists and our resource persons. So our first speaker is Prof. Catherine Sigbefia. Prof. Kathy is a consultant pediatric hematologist oncologist. She's currently the head of department at the Child Health Department at Kolubu Teaching Hospital. She's a professor in pediatrics at the University of Ghana Medical School. And she has a keen interest in hemoglobinopathies, like sickle cell disease, hemostasis, thrombosis, and hematologic malignancies. She's going to be our main speaker for today, and she'll go first. Followed by her is Dr. Teddy Totime. Dr. Totime trained at the University of Ghana Medical School and completed his neurosurgical residency at the Kolebu Teaching Hospital. He further specialized in pediatric neurosurgery with a fellowship at the Alder Hey Children's Hospital in Liverpool. Currently, he runs a neurosurgical practice at the Accra Medical Center. Our third speaker is Kukwa. Madam Kukwa Garnett has a background in cognitive neuroscience and neuropsychology. She has studied the brain-behavior relationship through both academic and clinical experiences. Her focus includes cognitive development, brain injury, and neuropsychological assessments. She's very passionate about applying neuroscience to improve cognitive health and patient outcomes. And Kukwa works at the Mission Pediatrics Mission Health Specialist Psychology Department. So, as you can see, we have a marvelous panel of experts to help to teach us more about pediatric strokes. And so, without much ado, Prof. Kathy, can you take the lead?
Thank you so much, and good afternoon, good evening, wherever you are. Can you hear me, Marilyn?
Yes, please. We can hear you loud and clear.
And you can see my slides.
And I can see your slides.
Perfect. It's such a pleasure to be back. Thank you so much for having me. Again, as you were introducing me and talking about my interests, I realized that every single thing that I like is connected to stroke. So hemoglobinopathies, hemostasis, which is bleeding disorders, thrombosis, hematologic malignancies, the one thing that ties them all together is stroke. So we're talking about the brain and we're talking about blood. And in a perfect world, everything goes well until it doesn't. We know that blood is meant to sustain the brain, but it can also, in some children, become the brain's greatest threat. And so over the next 30 minutes, we're going to explore how blood and brain interact when it comes to strokes. Now, some of the reasons why alterations in blood are linked to stroke are that there's either too much of a specific blood component or there's too little of it. So too much in the case of sickle cell disease, where you have sickled red cells, in acute leukemias, when you have a lot of blasts in the peripheral blood, so hyperleukocytosis, in polycythemia and thrombocytosis, where you have too many red cells or too many platelets. All of these can result in stroke. Now, conversely, if you have too few platelets, when there's severe thrombocytopenia, especially when the platelet count is below 10 to 20, that increases the risk of having a spontaneous bleed, which can occur in the brain. And then when you have clotting disorders like hemophilia and others, that can also result in a stroke. Now, sometimes there is a hypercoagulable state, and that can occur in sickle cell disease again, but also in the inherited thrombophilias. And the sort of commonest severe ones that we often hear about are deficiencies in the naturally occurring anticoagulants like protein C, S, and antithrombin. And then in leukemia, in acute leukemias, with or without chemotherapy, that can also result in stroke. Sometimes the hemodynamics are altered, and that can happen in the context of severe anemia, where the speed of blood flow can damage the vascular endothelium, But also when there's severe anemia, there's an increased risk of cerebral hypoxia, which can also lead to a stroke. Or if there's hyperviscosity, and we'll be talking a little bit more about hyperviscosity when I sort of like zone in into sickle cell disease, where the increase in viscosity reduces blood flow, increases vascular or the resistance to blood flow, and that can also result in a stroke. And if the wall of the blood vessel is damaged, so if you have endothelial injury, either in the context of sickle cell disease or if you have sticky blasts in leukemia that damage the wall of the blood vessels, that injury can also set up the environment for a stroke. So in today's presentation, we'll be going through some peculiar issues related to children and stroke, which really is just highlighting some of the points that were made in the very first part of this series a few weeks ago. We'll talk about sickle cell disease. It's often what people think about when a child presents with a stroke. And if the HB electrophoresis comes back and shows that there's no sickle cell disease, then people often get stuck. So don't get stuck. There are other things that you can think about apart from sickle cell disease, especially when it comes to hematologic causes. We'll also highlight why it is extremely important to do a thorough clinical evaluation. Marilyn mentioned time is brain. You're probably going to hear that over and over. And then the very best treatment for stroke in a child who has sickle cell disease is to prevent it from happening in the first place. So the best way to prevent a stroke is make sure that it doesn't happen in the first place. So anybody can get a stroke, even though we know that commonly strokes are typically associated with the elderly. They can occur across all the pediatric age groups. Now, this is important because sometimes it's very difficult for families to comprehend. And it's an important point in our counseling because it affects health-seeking behavior. So you can have people who don't show up in hospital on time just because there's the disbelief that this young child could have a stroke. Now, even though children do get strokes, often the causes are a little bit different than what we see in adults. And some of those causes were highlighted in the very first part of the presentation. Now, whether child or adult, the morbidity and mortality from stroke is significant. But the effects tend to be more devastating in children just because there's a longer duration of disability, potentially over that child's entire life. So imagine a stroke in a 60-year-old versus a stroke in a 6-year-old who still has their entire life ahead of them. And beyond the motor deficits and speech and other deficits, the things that are obvious, remember that childhood stroke changes that child's ability to achieve. And I'm sure that Kukwa will talk a little bit more about this in her presentation. So there are many things that can result as complications if a child survives that stroke. Cognitive impairment, which can affect more than 2/3 of children, problems with attention and memory, with their executive functioning. And this directly impacts what kind of profession that child can engage in when they grow up. So if there are significant cognitive deficits, then that has already limited what that child is able to achieve. The neurologists deal with post-stroke epilepsy that can occur in up to 20% of cases. You can have motor deficits, which could range from mild to severe, speech and language problems. Children learn by playing. That's how they develop. And if a stroke limits their ability to participate, then that can have an impact on that child's overall development. It's expensive to treat stroke, both directly from how much money you take out of your pocket to the indirect costs of the child not being in school, the parents not being able to go to work, funds being diverted from looking after other children in the family and so on. And of course, the overall effect on quality of life. So really, if that child doesn't die, there's still lots and lots of problems that can occur as a result of that stroke. So the summary is that overall, even though, adult stroke is more common and adult stroke is what the focus tends to be on, the truth is that the burden of childhood stroke, both on the child, the family, and the society, is much greater because that child is going to potentially live longer with those disabilities. So the types of stroke were mentioned in the first part of this series. I'm just going to highlight it again because it is related to hematologic causes. Okay, so blood disorders can lead to either ischemic or hemorrhagic stroke. And the way that I want you to think about ischemic stroke is thinking about, for those in Accra, just think about a traffic jam on Ring Road Central, right? So there are cars back to back, nothing is able to go through. So that's kind of what happens when there's an ischemic stroke, there's an obstruction, and blood isn't able to flow through. And this can happen in the arteries, what we typically refer to as arterial ischemic stroke, or it can happen in the veins. Now, CSBT is less common than arterial ischemic stroke. And because it's less common and people don't usually think about it, it's often underdiagnosed. If you do not look for it, you're not going to find it. And it tends to be particularly common in children who have acute lymphoblastic leukemia, who are on a specific chemotherapy called asparaginase. This tends to be given very early on in the treatment of leukemia, within the first few months of treatment. And it's important to have a high index of suspicion if you have a child with leukemia who presents with usually very, very dramatic signs of raised intracranial pressure. They have headaches, they have vomiting, they may have seizures, focal deficits, they may have reductions in their level of consciousness and so on. So in that scenario, it's very important to think about a CSVT because if you don't look for it, you're not going to find it. Now, with the hemorrhagic stroke, the problem isn't an obstruction, but there's blood leakage from the blood vessels. And there are things that can predispose to this leakage from the blood vessels. So what are the blood disorders that increase the risk of ischemic stroke? So sickle cell disease, I've mentioned before, I'm going to talk a little bit more about it in detail. But moya moya, which Marilyn mentioned, is a non-inflammatory vasculopathy, and it's associated with stenosis in the intracranial arteries, usually the distal portion of the internal carotid artery and its branches. And people who have moya moya are more likely to have a stroke because of the occlusion and stenosis of the blood vessels. Now, often when there's moya moya, you have compensatory mechanisms which allow for the formation of collateral vessels at the base of the brain. And it is the appearance of those collateral vessels that gives the puff of smoke appearance, which is seen when you do neuroimaging. So sickle cell disease with or without moya moya syndrome. Now, children who have leukemia, again, with or without chemotherapy, and the events or the cerebral events in leukemia can actually be due to various things. It could be from ischemia. It could also be from hemorrhage. And you'll see that leukemia can predispose to intracranial hemorrhage, especially because of the low platelets that are associated with bone marrow failure. But it could also be related to disease spread to the brain. So there are many different reasons why a child with leukemia could have a cerebral event. And so if they present with an acute or focal neurologic deficit, it's important to try and exclude all of these other things that could also cause that presentation. Venous thrombosis can happen in about a third of the acute CNS events in acute leukemias. And as I mentioned previously, many of them tend to happen early on during the first month of treatment or the induction phase of ALL treatment. And that's because during that first phase or first month of treatment, you still have active disease. There's a large blast population, and we're also using drugs like asparaginase and steroids, which increase the risk of thrombosis. The inherited thrombophilias I mentioned earlier, and then polycythemia. Now, for hemorrhagic stroke, think about bleeding disorders like hemophilia or acquired bleeding disorders, which could be related to clotting factors, things like DIC or liver disease, or thrombocytopenia from whatever cause, platelet function disorders. And with platelet function disorders, the absolute number of platelets may be within normal range, but the platelets don't work as well as they should. Anything that would cause a coagulopathy, and then sickle cell disease again. So with moya moya, those collateral vessels that have formed because of the occlusion are very, very fragile, okay? So yes, they are trying to compensate for the blockage, but because they're very fragile, they break very easily, and that can lead to hemorrhage. But just to say that by far, the commonest reason that there's hemorrhagic stroke in general is vascular malformations, either because there's a ruptured aneurysm or because you have an abnormal connection between the veins and the arteries of the brain, what is known as an arteriovenous malformation. So majority of the non-traumatic pediatric intracranial bleeds actually occur not from intrinsic hematologic problems, but actually because of vascular malformations. So these abnormal connections can easily burst and cause bleeding in or around the brain. So it's very important that we have a high index of suspicion for stroke. And this high index really depends on the clinical circumstances. So here's where your history and physical exam are extremely important. Now, age is there because in young children, the signs and symptoms can be very, very non-specific. Okay, so if you have, for instance, an infant who is favoring one hand, so the neurologist will tell you that before the age of 18 months, really, children they should be able to switch from one hand to the other. So if you have maybe a 9-month-old who is favoring a particular hand, that could be a risk factor, and that could tell you that a stroke has occurred. If there's fisting, if there are delays in achieving, especially gross motor milestones like rolling and crawling and walking and so on. And I've seen this, especially in children with sickle cell disease, where there's a mistaken assumption that there's pain, and that's why that child is not moving their hand. So a child in hospital had actually had a stroke, and it wasn't discovered until days later because people just assumed that the reason the hand wasn't moving was because there was an IV in and that the child had vaso-occlusive pain. So it's important for us to have a high index of suspicion, especially in nonverbal children. If there's a known underlying disorder, so you know this child has leukemia or this child has hemophilia, we've seen children with severe hemophilia who've come in with intracranial hemorrhage. And again, people didn't immediately sort of think about it, even though there was a history of trauma. And sometimes the history of trauma is very trivial. So there was a particular child with severe hemophilia B who he actually was wearing a helmet to school, and then the teacher said, "Oh, take off this helmet. Why are you wearing a helmet?" He took off the helmet and was playing and had what seemed to be a non-significant injury to his head. And he actually started to have headaches, was brought to hospital, and at the OPD, the medical officer thought that he had malaria, gave him antimalarials, sent him home, and it wasn't until he came back with seizures that the diagnosis of an intracranial hemorrhage was made. So in children who have a disease that puts them at increased risk of bleeding or of a blood clot in the brain, please let's think about stroke very high on our list when they present. When there's a family history of thrombosis, and this we see particularly in those who have the strokes from inherited thrombophilias like protein C, protein S. So if you get a history that people in the family under the age of 40 have had strokes or have had clots, that increases the index of suspicion. And of course, the signs and symptoms of focal deficit, of raised intracranial pressure. And in general, and this is not an exact science, but in general, when there's hemorrhagic stroke, the signs and symptoms of raised intracranial pressure tend to be more dramatic. So the loss of consciousness, headaches, vomiting, seizures. Whereas for ischemic stroke, most of the time they'll present with a focal deficit rather than things like loss of consciousness. So Be fast is a nice acronym to remember sort of the signs and symptoms, balance issues, changes in vision, if you have facial droop from a cranial nerve palsy, if you have a focal or motor deficit, if there's trouble speaking, and very, very importantly, the last one, which is the T, which is time. Time, time, time. As Marilyn mentioned, the hyperacute therapies which the adults use really have a very, very small time window within which they're effective. So getting the patient into hospital on time is very, very important. Time really is brain. Every minute that the stroke is untreated, millions of brain cells are dying. And it's very, very important that we start our interventions on time. And please do not be paralyzed, pun intended, by not having the means to do neuroimaging, not having CT scan, not having MRI. I've seen written in notes, awaiting MRI, awaiting CT scan. Please, you do not need to wait for those things before you start interventions, okay? You can start your interventions based on a clinical diagnosis. And remember that the WHO definition of stroke does not include neuroimaging. You can make that diagnosis based on your clinical features. Okay, so if you can't explain, there's no other explanation for this event that you're seeing, and there's a good likelihood that it could be from a vascular source. Even if you do not have CT scan, even if you do not have MRI, you can make that clinical diagnosis of stroke. Remember also that in our setting, there are many things that can preclude the availability of either CT or MRI. And even in the so-called tertiary or quaternary centers, sometimes the machine is broken down. Sometimes the machine is working, but the person doesn't have money to do it. Sometimes it's in the middle of the night and there's nobody available to run that scan. So even where those machines are there, they're not always accessible. A CT scan in the acute setting is often non-diagnostic. So even if the CT comes back and it is normal, it does not mean that a stroke hasn't occurred. And as a matter of fact, only about 5 out of 10 of non-contrast CTs, which are obtained at presentation, will show you any findings that are consistent with evolving ischemic changes. Non-contrast CT in stroke is often useful to rule out hemorrhage, not to rule in infarct. Okay, so it's a nice, quick way for you to say there's no bleed, but the fact that it's normal doesn't mean that an infarct isn't present. So the really important learning point from this slide that I'm showing is that you do not necessarily need neuroimaging right at the beginning for you to begin your interventions. So now, what are those important interventions? Well, what you do depends on what's causing the stroke, but there are certain basic principles that apply. And Marilyn alluded to these basic principles when she was giving her summary. Please, it is very, very important that you protect the rest of the brain. And what I want you to do is to just think about this question.
Kathy,
Under what
sorry,
conditions?
Kathy,
Yes,
let
yes,
me give
somebody
this an yes. John something is writing on the
is writing on the
John
screen.
Gerald. John Gerald, please stop writing on the screen.
I think you can disable, you can actually disable that feature for
Okay.
so the
PSG,
host can disable that.
yeah. PSG, please disable that feature for us. Thank you. Sorry, Kathy. Continue.
No problem. So I was just saying that time is brain. Protect the neurons and think about the conditions under which your brain cells function optimally. Now it's about, 4:30 p.m. in Ghana, and if you haven't had breakfast and you didn't have lunch, you're probably very hungry right now, okay? And if you're hungry, you're not going to be able to focus. If you're tired, if you're stressed, if you're hot, you're not going to be able to focus. So just think about that in terms of your neurons. Manage fever, manage dehydration, manage acidosis, correct electrolyte imbalance, make sure that there's no hypoxemia, give oxygen, manage hypoglycemia. I mean, these are things that you can do even if you do not have neuroimaging. These are things that are important, whether it's an infarct or whether it's a bleed. So even if you don't know at that specific point in time exactly what you're dealing with, these are still interventions that are important. Control seizures. These are all modifiable factors that can result in further neuronal injury. But please be very, very careful about blood pressure. Notice that I didn't say anything about blood pressure. And Dr. Totime probably will talk a little bit more about this. Remember that when there's raised intracranial pressure, as a compensatory mechanism to maintain the cerebral perfusion pressure, the mean arterial pressure, the systemic blood pressure will go up. That is the body trying to maintain blood flow to the brain. So if you go being aggressive about dropping the blood pressure, what you're going to do is worsen the situation, okay? So be very, very cautious. Don't go chasing the blood pressure because you could actually make things worse. Now, for hemorrhagic stroke, reverse the coagulopathy. So if this child has severe thrombocytopenia, then they need platelet transfusion. And just to say that you cannot use other blood products as a substitute for platelets. So if the person needs platelets, they need platelets. So you can't say, well, the platelet count is 2. I don't have platelets available, so I'm going to give frozen plasma. It doesn't quite work like that. So depending on what factor is missing, you should replace it. Call the neurosurgeons if you're concerned about hematoma, something that requires surgical evacuation. Now, for ischemic stroke, again, as Marilyn said, the hyperacute therapies like thrombolysis and so on, apart from the very, very strict early time window where these are known to be effective, there's really still not a lot of evidence in children, even though more and more places in more developed countries are turning to hyperacute therapies. But that's because patients tend to present early and within the window where those therapies make sense. We usually will use anticoagulation. We do have to balance the risk of anticoagulation against causing further bleeding. And so usually we will start with unfractionated heparin. And we use IV unfractionated heparin because it's easy to reverse if bleeding occurs. So we start with unfractionated heparin. After a couple of days, we will do a non-contrast CT just to make sure that we haven't caused any more bleeds before we transition to low molecular weight heparin or other antithrombotic therapies. Now, for sickle cell disease, the key thing is transfusion, okay? So transfusion is very important in that acute setting. And the goal of transfusion is twofold. The first is that what you're trying to do is to quickly reduce the percentage or concentration of hemoglobin S. You want to get it down to below 30%, okay? But the second thing you want to do is that in a bid to reduce that hemoglobin S to less than 30%, please do not cause hyperviscosity by taking the HB too high. So you're reducing the percentage of hemoglobin S, but at the same time, your goal or target HB is about 10 grams per deciliter, certainly not greater than 11 grams per deciliter, okay? So the goal of transfusion in that acute setting is reduce the S to less than 30%, but do not take the HB higher than 10 to 11 grams per deciliter. Now, why wouldn't you want to take the HB higher than 10 to 11 grams per deciliter? Well, remember that there is a direct relationship between the hematocrit or the HB level and viscosity. As the hematocrit goes up, the viscosity also goes up. And viscosity will continue to go up. Initially, oxygen delivery will improve, but at a certain key point, even if the HB continues to go up, because the blood has become so viscous, so thick, and is not flowing properly, then oxygen delivery actually starts to drop. So at that point in time, the increase in HB is detrimental. Now, if you do not have sickle cell disease, the point at which the increase in HB becomes detrimental is much higher than if you have sickle cell disease. And that's because the sickled red cells increase the viscosity in themselves. Because they're so sticky, because they're so stiff, because of their sickled shape, they increase the viscosity in themselves. So if you have two people, one who has sickle cell disease, one who does not have sickle cell disease, with the same HB level, the person who has sickle cell disease has a much higher viscosity than the person who does not have sickle cell disease. And so in the context of sickle cell anemia in particular, increasing the HB beyond 10 to 11 does not serve any purpose. And as a matter of fact, actually becomes dangerous. How do you transfuse? You can use a simple transfusion, which is what is available to almost all of us, or you can do an exchange transfusion. An exchange transfusion just means that you're not just topping up with blood, but you're also taking out the person's blood as you're giving them donor blood. Now, in the context of stroke, the exchange transfusion is better in that acute setting. The exchange transfusion is better. The first is that when you do an exchange transfusion, you are more likely to be able to drop that S percentage to less than 30%. You're able to do it faster. The second important reason is that the exchange transfusion limits the increase in viscosity because you're not just adding on, you're taking out as you're adding on. So when you do an exchange, you minimize that hyperviscosity that occurs when you're just doing a top-up transfusion. So exchange is preferred to a simple transfusion, but if you do not have the ability to do an exchange transfusion, and this child has an HB that is below 8, they're anemic, HB is like 6 or 7, then you can do a top-up transfusion, but please make sure that you do not exceed that 10 to 11 target. Now, if the HB goes up to that 10 to 11 target, and you haven't achieved the less than 30% S percentage, then it's time to do an exchange transfusion. And actually, in a lot of places, if the child presents with severe anemia in the context of a stroke, they will start off with a simple transfusion because that's easy to do while you're getting ready to do the exchange, because the simple transfusion often will not result in that drop in HB that you want. That drop in HBS, the percentage of HBS that you want. So exchange preferred to simple, but if you don't have exchange transfusion, you can do a simple transfusion with caution. Now, I'll just highlight a little bit about what you do in immune thrombocytopenia, ITP. We typically will do what I call the kitchen sink approach. And the kitchen sink approach means that we literally throw everything at that child who has presented with an intracranial bleed in the context of ITP. And you're doing that because you want to very, very rapidly increase the platelet count. Now, typically in ITP, you wouldn't give a platelet transfusion because it's a consumptive process. If you give the platelets, they're just mopped up by the antibodies that are present in the circulation. But in this instance, you will give platelets and you'll give intravenous immunoglobulin, you'll give pulse steroids. If you have access to thrombopoietin agonists like romiplistim, it is given parenterally, you will give that. So you literally throw everything, every therapy that is effective in ITP, you throw everything at that child just to try and get the platelet count up as quickly as possible. But just know that in intracranial hemorrhage in ITP, you give a combo of modalities, including platelet transfusions. So this is where you would use platelet transfusions in ITP. Now, in severe hemophilia, if that child presents with an intracranial hemorrhage, what I want to highlight is factor replacement. Factor replacement should be performed before you do anything else. In fact, even if your CT scan is up and running, even if the tech at CT has said, bring the child right away, please give factor replacement first before that child has or goes for any radiological examination or has any consultation. Because every minute that that child does not receive factor, that hemorrhage is getting worse. Now, intracranial hemorrhage in hemophilia, it tends to be commoner in the younger children, so less than age 2 years. And it could be associated with mode of delivery or the trauma of delivery, like prolonged labor, instrumentation, and so on. Or, the child being forced through the vaginal canal, so in the newborn period. But the most relevant risk factor is the severity of hemophilia, okay? So children who have severe hemophilia are the ones who are most likely to present with intracranial hemorrhage. So factor first, and you're aiming for about 100% correction of factor within the first 72 hours at least. Ideally, you should try and maintain about 100% correction in the first 7 days. And you're doing that to stop the bleeding and to prevent expansion of the hematoma. And then subsequently, from the end of that first week, you can step down to about 50% correction. And this correction, I'm talking about the trough level, which is the factor level before you give the next dose. And often this requires either giving factor every 8 hours. Sometimes you even need a continuous infusion of factor. So you might have to do a continuous infusion. You might have to give it 8 hourly or 12 hourly. But it's very, very important that you do this in conjunction with somebody who has expertise. So even if you have factor available in your facility, give the first dose, call, and get some guidance in terms of what to do next and how to continue to maintain if you're not able to refer that child. If you don't have factor in your facility, still call. We've had situations where we've been able to send factor to other health facilities to help them with managing patients like this. We usually will individualize the treatment, so we use the peak and trough factor levels to guide our therapy. And we will treat for up to 3 weeks. Usually a minimum of 2 weeks if you have limited availability of factor. But usually we will treat intracranial bleeding hemophilia for up to 3 weeks. And these are children who should have lifelong secondary prophylaxis. All right. So in the next sort of like maybe 10 or so minutes, I'll talk about sickle cell disease and stroke. The first thing I want you to keep in mind about sickle cell disease is just how complex the pathophysiology is. And when I teach medical students, I usually tell them that in thinking about the pathophysiology of sickle cell disease, think SCA. So SCA is the abbreviation for sickle cell anemia. It's an easy way to remember because this is a condition that affects the red cell shape. So that's the S. It affects the consistency. So how that red cell behaves, how deformable it is. Okay, that's the C. And it also affects the adhesiveness of the red cell. So sickle-containing red cells tend to be very, very sticky. So they stick to each other and they also stick to the vascular endothelium. But sickle cell disease goes beyond just red blood cells. It is actually a chronic vascular disease. Okay, it's a chronic vascular disease. And over time, there is smooth muscle proliferation and intimal hyperplasia. And remember that all of these changes are happening, whether that child is in hospital, whether they're at home, whether they're in school, there is ongoing silent vaso-occlusion. Now, I'm going to tell you a short story. And at the end of the presentation, we'll look and see what went wrong in that short story. It really is a sad story. And I just, get all emotional when I think about it because this was really a series of unfortunate events. A 7-year-old girl known to our clinic had a stroke at the age of 4 years. She was initially on chronic transfusions and then was transitioned to hydroxyurea. In fact, had been on hydroxyurea, but didn't quite tolerate it well. Then she had the stroke, put on transfusions. We managed to get her back on a decent dose of hydroxyurea. Her baseline hemoglobin was somewhere between 7 and 8 grams per deciliter. Now, a couple of months ago, she became unwell and dropped her HB to about 3 grams per deciliter. And she was seen at a private hospital. This is a private hospital that has pediatricians. The pediatricians are not the ones who saw, but this is a private hospital that has pediatricians, so they could have been consulted by the person who saw. Now, this person who saw rightly made a decision to transfuse because the HB was 3. But here's where the problem began. That this 16-kilo, 7-year-old girl received 3 units of blood within 36 hours. So got a first unit on a Saturday morning, got a second unit on a Sunday morning, and got a third unit on a Sunday evening. And between these 3 transfusions, there was no full blood count or HB check. Now, 2 days after the 3 transfusions, the HB was more than double what her usual baseline is, so 14.5 grams per deciliter. And not surprisingly, within a few days, she had had another stroke. Now, children with sickle cell disease are particularly at risk of stroke. They have more than 1,000-time or 1,000-fold increase in the risk of stroke compared to people who do not have sickle cell disease or do not have heart disease. It's important for us to recognize some other terms that are associated with stroke in the context of sickle cell disease, because it isn't always the overt stroke that we know. So there are silent cerebral infarcts, and silent infarcts just mean that there is imaging or neuropathologic evidence of infarction. However, there's no visible acute neurologic dysfunction. So the typical motor deficit that you'd expect that is attributable to the lesions that are being seen in the brain are absent. So that's why it's called silent. And then there's also transient ischemic attack, where you have overt stroke symptoms, but they last for less than 24 hours. And when you do neuroimaging, there's no objective evidence of infarction. So notice the difference, that with silent infarcts, you have objective evidence of infarct, but clinically, you do not have the typical neurologic signs that you'd expect in stroke. And with a transient ischemic attack, for less than 24 hours, that child will present with an acute neurologic deficit. However, on imaging, there's no objective evidence. Now, silent infarcts tend to be quite common, especially in sickle cell anemia. And by the age of 18 years, almost 40% of children with sickle cell anemia will have evidence of silent infarcts. Now, why do we care about silent infarcts or transient ischemic attack? Well, silent infarcts can cause cognitive dysfunction. Okay, so they can result even if there's no motor deficit, even if there's no speech or language deficit. Silent infarcts can influence that child's ability to achieve. So it can affect their IQ and it can cause learning difficulties. And if you have a child with sickle cell anemia and who suddenly stops doing well in school, their grades deteriorate and so on, then it's important to think about a silent infarct. But also, both silent infarcts and TIAs increase the risk of overt stroke. So let's look at some of the other risk factors for stroke. The first is the type of sickle cell disease. And if you look at the graph on the right side of the screen, every time the line goes down, a stroke is happening, okay? So every time, so the lower the line, the more strokes are occurring. And you can see that the lowest line is from those who have hemoglobin SS genotype. So strokes tend to be commonest in those who have SS genotype. 11% will have a stroke by the age of 20 years, compared to 2% by the age of 20 years if they have hemoglobin SC disease. And the highest risk period for that stroke is within the first decade, typically within the first 5 years, between ages 2 and 5. So this is really the time when nobody expects that a child will have a stroke. And for sickle cell disease, that's the highest risk period. The second has to do with clinical and lab risk factors. So the clinical risk factors I already mentioned, silent infarcts and TIAs. Acute chest syndrome is also a risk factor for stroke. And the reason that acute chest syndrome is a risk factor for stroke is that both stroke and ACS are driven by the same mechanism. So vaso-occlusion, inflammation, increased metabolic demand, tissue damage, hypoxia, all of those things are common to stroke and to acute chest syndrome. And so recent acute chest syndrome or multiple episodes of acute chest syndrome increase the likelihood of stroke. Children who have nocturnal hypoxemia, for instance, those who have enlarged adenoids with obstructive sleep apnea, are also at increased risk of stroke. And then if children who have relatively lower steady state HB levels, remember I talked about severe anemia and the endothelial injury that can occur because blood is, the body is driving blood through, is trying to pump blood through much faster to try and compensate for the low HB, to try and improve oxygen delivery, and that can cause endothelial injury. And then moya-moya syndrome, which I already mentioned, and what you're seeing on the screen is that puff of smoke appearance on angiogram because of the development of the collateral vessels. And TCD. Now, TCD is something that's not widely available for us in Ghana. There are only a few places that are able to do a transcranial Doppler velocity. But this is a very, very important non-invasive ultrasound technique that actually predicts the risk of stroke. And it does this by measuring how quickly blood is flowing through the cerebral blood vessels. So you're measuring the velocity of blood flow non-invasively using ultrasound. And in sickle cell disease, the vessels of interest are the middle cerebral artery and the distal portion of the internal carotid artery. And what we use, the type of velocity that is used is the time averaged mean maximum velocity. So it's not the peak systolic velocity, it is the TAMMV. And that is very, very important because sometimes we get reports that are that have measured the peak systolic velocity. But in the context of evidence for sickle cell stroke, it is the time average maximum mean velocity that is predicted. So how is TCD velocity stratified in the context of stroke? If you have a child who has sickle cell anemia, and here I'm specifically referring to SS or S-beta thal not, if they have a TCD velocity that is less than 170 centimeters per second, then their annual stroke risk is about 1%. Okay, it's about 1%. And that's kind of what the typical stroke risk is for somebody who has sickle cell anemia. Now, if that TCD velocity increases to between 170 to 199 centimeters per second, then the stroke risk jumps to 3 to 4% per year, okay? So it almost triples or quadruples from less than 170 centimeters per second. However, if the TCD velocity in either the internal carotid or the middle cerebral artery is 200 centimeters per second or more, then that stroke risk increases to more than 10%. And 40% of children who have a TCD velocity that is 200 centimeters per second or greater will stroke within 3 years. Okay, and so you can see that using TCD velocity, this is a very, very important way of identifying those who are at very high risk of stroke. Please, TCD is predictive of stroke before it occurs. We have seen situations where a child has had a stroke, is in hospital, is being managed for the stroke, and people are scrambling to do TCD. If you're scrambling to do TCD after the stroke, you've missed the boat, okay? So TCD is predictive before the stroke occurs. And that's why it's important that children, especially between the ages of 2 years and 16 years, who have HBSS genotype or HBS beta thal not, should have TCD screening as part of their routine follow-up, because you can then identify those who are particularly at high risk, and you can intervene to try and prevent that stroke from occurring. And in developed countries where TCD screening is done routinely, they have virtually eliminated stroke. Like children with sickle cell anemia do not present with stroke because they are picked up before the stroke happens. However, by far, the biggest risk factor for a second stroke is if you've had one before, okay? And if you've had a stroke before and nothing is done, there is no intervention to try and prevent another stroke, you can almost guarantee that that child will stroke again, okay? You can almost guarantee that that child will stroke again. And the second stroke often will happen fairly quickly within the first 3 years of the initial stroke. Now, what this means is that every single child with sickle cell disease who presents with a stroke must be offered a strategy to prevent another stroke. You cannot let that child walk out of your clinic. You cannot let that child walk out of your consulting room, walk out of your ward, walk out of your hospital without offering a secondary stroke preventive strategy. I mean, that is just simply malpractice, because you can almost guarantee that that child is going to stroke again. Okay, now these secondary interventions are not 100% protective. Okay, you can't say that if I put this child on chronic transfusions or hydroxyurea or whatever else, they will never have a stroke. No, they're not 100% protective. But what you're doing is significantly reducing the likelihood that another stroke will occur. So ideally, because none of the secondary preventive strategies are 100% foolproof, ideally, what you want to do is prevent the first stroke from occurring in the first place. And the way to do that is using TCD as a routine screening modality. So just coming into the final few slides, here is an algorithm for how you screen with TCD. So a child, 2 to 16 years, SS, S beta thal not, who has a normal TCD, you've done it, the velocity is less than 170, then you can do it every year till they're 16. Beyond the age of 16, there's no evidence to show that continuing to use TCD is helpful. Now, if that child has a conditional velocity, so it's not quite abnormal, not quite normal, then you need to look a little bit more closely. And the reason is that conditional velocities can convert. They can actually convert from being conditional to being abnormal. Now, if they are low conditional, between 170 and 184 centimeters per second, then you can repeat the TCD every 3 to 6 months. If they are high conditional, between 185 to 199, then you should check again after a month, okay? And if after a month it's still conditional, you can continue to repeat every 3 months. Now, if you have a child who has an abnormal TCD, 200 centimeters per second or greater, if it's borderline abnormal, ideally do it again within 2 weeks. And the reason you're doing it again is because there are things that can interfere with the TCD velocity. If that child was crying, was sleeping, was hungry, had a fever, and so on, all of those things can interfere with the TCD reading. So repeat it again within 2 weeks. And if it's still abnormal, then you want to offer them interventions for primary stroke prevention. You also want to go ahead and do an MRI and MRA, because remember that the TCD is telling you that there's something going on, there's something that's going on within the intracranial vessels. So you want to visualize that circle of Willis, visualize the brain, and see if you'll pick up anything more. Now, if you have a TCD velocity that is greater than 220, you don't need to do it again. Go ahead and start the interventions for prevention. Now, TCD costs money. So if funds are a concern and you have a borderline increased TCD and the conditions for doing that TCD were optimal, you really don't have to do a repeat. You can go ahead and offer the options for primary stroke prevention. Now, the flip side of a high TCD is a very low TCD. If you have velocities that are less than 70, this is telling you that there's so much occlusion that blood can barely flow through. And so when the velocities are less than 70, that's also cause for alarm and should trigger further imaging and further interventions. So how do we manage to prevent a first stroke? What are the primary stroke preventive measures? Chronic transfusions every 3 to 4 weeks, simple or exchange. And this has been shown to be very effective, reducing the stroke risk by 92%. But the problem with transfusion is that we don't have enough blood. There are risks to it. It may not be feasible, it may not be acceptable, it may not be sustainable. And so, again, you have to consider the patient in front of you, consider the resources that you have. But hydroxyurea has also been very, very effective in primary stroke prevention. And this is hydroxyurea at maximum tolerated dose, MTD. So even though you start off at a lower dose, it's important that you optimize the dose of that hydroxyurea. You can start upfront with hydroxyurea, as was done in the SPIN trial, or you can give transfusions for a year and then switch or bridge with hydroxyurea. But hydroxyurea doesn't work for everyone. For those who have significant vasculopathy like moya and so on, hydroxyurea doesn't work quite well. And in those situations, you want to think about other options like transfusions or gene therapy or stem cell transplant. And because it's medicine that people have to take every day, often adherence can also be a problem, particularly in the teenagers. So other things are revascularization surgery, which I'm sure Dr. Totima will talk about if you have moya with or without transfusions, and then gene therapy or stem cell transplant. Just remember that gene therapy or stem cell transplant will not reverse the vasculopathy that's already present. And in some patients, there has been progressive cerebrovascular disease despite a transfusion. So these are the ones that you will want to offer gene therapy and stem cell transplants if they're available. Or in those who, despite transfusions, continue to have persistently elevated TCDs. There was a drug on the market, voxelotor. It's now been withdrawn, so I'm not even going to talk about it because that's not an option anymore. When do you repeat the TCD? If you're doing chronic transfusions, you can repeat every 3 months, and you do it just before the next transfusion. If it's hydroxyurea, there's no point repeating it until you've achieved maximum tolerated dose. I already mentioned this. Please do not do TCDs when children are sick because the velocities that you get will not be reliable. Now, if the person has already had a stroke, you can use chronic transfusions or hydroxyurea, but none of those works very well once a stroke has already occurred. But transfusions are better than hydroxyurea, and hydroxyurea is better than nothing. Doing nothing is not an option. So, finally, in this patient, what were the issues? The first was that this child's baseline HB is 7 to 8. And even though she presented with an HB of 3, the transfusions that were given were too aggressive. So it's very important to remember that it's not only how high the HB goes, but it's also how quickly you raise the HB. So you don't want to increase the HB too quickly. So viscosity is affected by the rate of rise of HB. And this very aggressive increase in the HB to 14.5, like staggering. I don't think my HB is even 14.5. 14.5 within 36. It probably was even higher than that because the check in HB was done a couple of days after the third transfusion. So it may even have been much higher than that immediately after the transfusion. But this was really too aggressive. So rapid increase in the HB and then taking the number to 14.5. And that is what triggered this new stroke that this poor child had. So this was completely avoidable. And I've presented it here just so that it's a learning point for everyone. Please do not be too aggressive when you're transfusing a child with sickle cell disease. So in summary, hematologic disorders can predispose to both ischemic or hemorrhagic stroke. Always think about sickle cell disease. That's very important, especially in our environment. But remember that there are other hematologic conditions that can also result in stroke. Remember CSVT, particularly in children with leukemia. Remember that time is brain. Don't be too hung up on whether or not you have imaging right away. Protect the neurons. Do all of the things that will make the brain cells happily. And very, very importantly, in sickle cell disease, we should prevent the first stroke. But if unfortunately that first stroke does happen, then we should do everything to try and prevent more. So thank you very much for your attention, Marilyn. I'll turn it back to you.
Thank you very much, Prof. Very extensive and detailed presentation. Our next presentation is by Dr. Teddy Totime. Please put your questions into the chat box. We will answer all questions after the three panelists have presented. Also, we will put in a link for you to be able to register for your CPD points, and we'll also put in a link for you to be able to evaluate the program before we finish. Please make sure that you are not fiddling with your gadget such that you are writing on the screen. It tends to be very distracting. I'm writing names. I have three names here who have been writing on the screen. Please do not do that. In case you don't know, sometimes it's by accident. I've seen Kate, Sophia, and John Gerard who were writing on the screen. John stopped immediately. Thank you. All right, Teddy, please go ahead.
Thank you very much. Thank you very much. And it's my privilege to spend some time this evening as we look at this topic that is really so important. It's always a pleasure listening to Prof. And listening to her teaching. And as I was listening, I just kept, taking slides out of my presentation because she really handled those topics. But I think that ultimately at the end of my presentation, which I'm going to start now. I think at the end, what I want us to just come to an understanding of is the fact that, pediatric strokes are a multi-specialty thing, multi-specialty challenge. And the more we collaborate on the treatments, the better. It's good that we're learning together, and it should also show in how we manage these patients. So this point has been, belabored, but I think I can just stress on the fact that the African population bears a disproportionate burden of this impact. And the stroke incidence has been increasing over the last 2 decades. And so this is definitely something that we should think about. And this increase has not been just in adults, but it's also been in children. And so it's a good thing that we're looking at pediatric stroke and looking at it so comprehensively. Now, these are some of the incidences that I saw, but the key thing about this slide is how much of the map is white. All the white areas on the map indicate that there's no data. There's no really significant data. So for this condition, which is of such high mortality in our environment, 22%, as compared to 4% in high-income areas, with such significant long-term morbidity. For a continent where we are 50% under 18, if you have 50% long-term morbidity, then it's significant implications on the future. So definitely something we should really keep thinking about how to deal with. And I think that the discussions that we are having now are very important. Now, the causes have also been listed and discussed by Prof. I think the key thing I wanted to also emphasize was the fact of trauma, and its association with venous thrombosis, especially for these children who, thank God, in our environment, children with traumatic brain injury, it's not as common, but we would, we'll continue to see them, and it's something that we should think about. The cranial sinovenous thrombosis in relation to trauma, and then also the fact that they can have, internal carotid dissection, also related to thrombosis and related to ischemic events. And so the risk factors are always going to be with us. Sickle cell has been discussed significantly. I mean, connective tissue disorders that we don't really see much about, but Prof has discussed, the coagulability disorders. Of course, I would put in the traumatic brain injury as a factor, and then also sickle cell, cranial infections. We've seen quite a few ischemic events related to subdural empyemas, subdural, so mainly subdural empyemas that extend from sinusitis, cerebral abscesses. So we've seen associated, ischemic events, and a lot of times those ischemic areas end up being the trigger points for, the seizures that follow these patients after they have been treated surgically. And so I think that these risk factors we should keep an eye on. And like Prof said, it's always about keeping, a very, a very eager eye, keeping a very high threshold of, care for these patients. I'm blocking exactly on the word I wanted to say. But, the one thing that I want to add is that in the post-COVID-19 era, we're having an increase in ischemic events, ischemic strokes. And it's interesting that even at the moment, COVID is rearing its head again. And especially in our environment where we do not have too many symptomatic COVID infections, it's something that we should really think about, because COVID and its impact on, the angiotensin system and its implications on, endothelial problems and hypercoagulability problems, and also hemorrhagic problems. It's something that we should really, put our suspicion on, and we need to investigate these factors a bit further. So just putting all of these, I wanted to just convince you about the neurosurgical place in stroke care, right? especially for children. I think as far as for adults, it's been quite proven that surgery plays a role and makes a big difference. For pedics, it's not that established. However, there are a few things that we can sort of look at, which can push us more into accepting the presence of neurosurgeons in pediatric stroke. First of all, anatomically, right? The special ways in which, and I'll discuss it in the next slide, the anatomic variants of the brain in children, and the fact that the compliance is quite reduced, and the space for swelling is reduced, and so surgery sometimes is so important to improve the outcomes in these patients. And the fact that sometimes these presentations can be very acute. And I think it was made very clear that children tend to present later than adults. And so by the time they come, they are, getting close to extremes. And in these periods, sometimes intracranial pressure can be so high that surgical intervention becomes important. For the stroke types, generally, it's not arguable that hemorrhagic strokes a lot of times in the right selection of patients can make a very significant impact when surgically tackled. And then, of course, the risk factors, some of the risk factors that we've spoken about. So the child's brain has a smaller subarachnoid space, smaller cisternal compartments, and so there's just very little space for the brain to swell into, right? So the tendency for delayed diagnosis ending up in large hemispheric, infarcts, or ischemia that is involving large areas of the brain is high. So the tendency for these, stroke events to involve a much bigger part of the brain than in the adults, right, is high. And once a much larger part of the brain is involved, then it would mean that, neurosurgical help would be, important. Now, the other thing, the penumbra evolution that has been quite well studied in adults, it's not been, so well studied in children so far. And so the decision making that we premise on, the amount of penumbra that we can deal with and what is safe to go in for decompressive craniectomy and what is not safe and stuff, it's not established, right? So considering the fact that, children with strokes tend to do better than adults with strokes, it's also that, part of the anatomy and the physiology of the kid that should make, neurosurgical intervention, more of a rule rather than an exception. At least for each of these children with strokes, there should be neurosurgical involvement. There should be neurosurgical oversight, so that if decisions need to be made for surgical intervention, those can be made timelessly. Now, children are more likely to report with reduced consciousness when it comes to strokes. They are more likely to have an acute presentation, right? Even though, children would also have the atypical presentation where they are not exactly, becoming hemiparetic suddenly. but also would be waxing and waning with the hemiparesis, right? What seems like a TIA, but it's actually an evolving stroke, right? And then they would also have those atypical headache, pain, confusion, collapse, right? So, like Prof was saying, sometimes, it's the suspicion that should, lead the way. And it's also the fact that, we should not, I'll take this away from her presentation, we should not let, the lack of neuroimaging paralyze us. We should really maintain a high index of suspicion and keep looking out for these signs, look into the history very closely, look into the risk factors that the baby, the child has, and make decisions based on those observations. I think the other reason why neurosurgery has become, our interventions must be part of the armamentarium is the fact that we have reliable neuroimaging diagnosis, and it has made neurosurgical intervention much more accurate, much more impactful, and the CT scan is the workhorse. But it's just that we should remember that most of the cytotoxic changes would appear after 6 hours for the CT scan. But again, those suspicious, that suspicious looking gray-white matter differentiation, that brain that is looking so full, you can't see any CSF around it. You're seeing some hyperdense vessel lines, those are really critical, and we should add a CT scan to a high index of suspicion that has been established clinically, right? And we need to, because as you can see from these two CT scans, the top one is for hemorrhagic. That is basically instant. It would happen. But the bottom one is for, an ischemic. And by the time an ischemic CT scan gets to this point, you can imagine that, a lot of time has been lost. And Prof mentioned that point in her presentation when she cautioned on the CT, the fact that they would miss almost 50% of strokes, which would later be confirmed by MRI, right? So if you're going to depend on neuroimaging, in order to make decisions, it can, come back and bite you, can come back and bite us clinically. And so the key thing about these strokes and looking at stroke treatment is, the clinical assessment and the high index of suspicion. The MRI is the most sensitive and specific of these diagnoses, and a lot of the changes that would happen from ischemia would be caught right in the first 30 minutes. And so, and then, the DWI, which is the diffuse weighted imaging, which is really important for showing the stroked areas, can be done in 30 seconds. And so sometimes, even though the MRI is not, for unstable babies or unstable children, it can yield a lot of information, and sometimes just interacting with the radiology text so that we can decide on the sequences that are most important can help, because we do not need to do the whole 30-minute sequence if all our answers could be in one or two sequences. And so again, multimodal stroke care, which would involve, the radiologist, it would involve the neurosurgeon, it would involve the pediatrician, would involve the radiology tech, and ICU staff and stuff. Then it's ultimately the more we are involved with others, the better. And these MRIs are showing, the top is showing. Let me see if I can get a. No, I can't get a pointer. But I have 3 MRIs here, and the top is showing, an area of ischemia, right, that has, developed slowly. The one in the middle is actually showing, if you see where the arrow is pointing, a clot in the sinus, and so the transverse sagittal, the transverse sigmoid sinus junction, it is showing a clot there. This is going to be a patient who has a craniosynovenous thrombosis. And then the bottom one is showing a hemorrhagic stroke in the temporoparietal area. There are some adjunct diagnostics tools that make surgical decision making easier, because the MRI is famously known for taking a long time. Some of the CT perfusion tests, which we do not have, I haven't seen it in Ghana yet, but it's very helpful. It's sort of like the poor man's DW diffusion weighted imaging, and it can show very clearly the stroked areas. It's just that it tends to be showing more of the central stroked areas rather than and it would tend to miss the more distal, peripheral stroked areas. However, it's a very good tool for helping to make a decision, a surgical decision on whether there should be a decompressive craniectomy or not, right? The CT angio, CT venogram are helpful adjuncts because they can be done at the same time with the CT. It's just that, the patient has to be given contrast. And this is why for a lot of centers, they would rather do the MRA and MRV, because for those you would not need contrast and they can be done time of flight. But the CTA, CTV for a relatively stable patient, it would yield a lot of information that can guide the surgeon on whether to intervene or not. The digital subtraction angiogram is sort of like the gold standard for looking at vessels, looking at is there any narrowing? Those collaterals in Moya that Prof was talking about, they come very clearly be seen when you look at them on the digital subtraction angiogram, right? But the digital subtraction angiogram has its own risks, and in terms of, it's not exactly a benign procedure. There are risks of further strokes, risks of the procedure itself. And so generally, if the information can be gotten from a CT angio and an MR angio, usually it's best done there. Now, the Doppler ultrasound, the transcranial Doppler that Prof really discussed fully, just to say that they're getting more and more advanced, and getting more and more of a clearer picture. You can see from the one below the fact that you can actually imagine that there's a circle of Willis that you can see, and this is just transcranial, transtemporal, right? And so I have a lot of hope that that part is just going to get better and better. And very soon we will not need to send babies from, the ward to go to cold CT rooms to get information that we can get with an ultrasound. So I would say that if you've got an ischemic stroke and it's involving, the middle cerebral artery, big branches, and it's involving an area, that is likely to continue to swell, the neurosurgeon must be called in. If there's associated cerebral venous thrombosis, just because there can be swelling initially that would need decompressive craniectomy to be done before the anticoagulation, the neurosurgeon should be notified. For moya moya, increasingly it's becoming a surgical disease because the medical treatment is not working on the in the long run, and even simple surgical interventions like just bare holes sometimes can be more impactful than long-term aspirin for moya moya. However, if that's all we have, then that's all we have. But it's important that neurosurgeons be involved in the working up of these patients, because the interventions that are available are very effective. The revascularization can be indirect or direct, and both of them have very good outcomes. And as long as the neurosurgeons have the skill, it is something to really think about. On the hemorrhagic side, I think there's no argument. If an aneurysm has ruptured, a neurosurgeon needs to be involved. The ruptured AVMs are the key cause, like Prof mentioned. And of course, the moya moya. The moya moya tends to be that in the children, in the much younger children, they'll tend to have ischemic episodes, whereas in the older children, they'll tend to have more hemorrhagic episodes. So moya moya features both for ischemic and hemorrhagic. Right. So just a few thoughts on some of the risk factors that I mentioned. COVID and stroke. I think I may end up being a bit controversial, but let me just say this is something that we should keep our eye on and do some more work about. And of course, if we don't find anything, we don't find anything. But ultimately, stroke has, gotten worse as far as incidence concerned in the post-COVID era. And the link between ischemic stroke, intracerebral hemorrhage has always been known. We've known the pathways. We know that it induces inflammation in the walls, and then also leads to hypercoagulability, vasculopathy, and then just a vicious cycle that makes just the right environment for ischemic stroke and intracerebral hemorrhage. Now, we haven't really had a big problem with COVID like other countries have had. But the truth is, we do not really have any numbers on our asymptomatic infections. And would asymptomatic infections do the same as symptomatic infections when it comes to, the blood vessel impact? That's something that we should think about and research a bit into. Prof has spoken quite a bit about sickle cell anemia. I have nothing else to add. The fact that it may evolve into moya moya, and the fact also that as far as sickle cell anemia is concerned, we would tend to stay away unless it's very indicated. I'll show us. I'll discuss a case of a sickle cell patient who came with an aneurysm that we had to treat, right? But I think ultimately, because of the significant arteropathy with sickle cell, interventions that would be, carried out in the non-sickle cell can be dangerous in the sickle cell patient. So generally, unless it's very indicated, treatment tends to be conservative and medical in patients with sickle cell anemia. Arterial dissection is basically a surgically managed intervention. And it's just something that, as our arsenal has increased with endovascular surgery, arterial dissections, especially carotid dissections that are causing ischemic episodes, have become treatable just by putting in a stent, and that is done endovascularly, right? So again, open treatment of these patients is rare, and even worse in the kids. There's a lot of sometimes discussion about whether endovascular treatment is, advisable for these kids. But the truth is that in these kids, endovascular procedures can be actually easier than in older people, just because the kids' vessels are so straight. There are no twists and turns, the insults that come from hypertension, diabetes, and things like that have not happened yet. And so sometimes the endovascular treatments can be very straightforward in these kids, as long as we can get small enough catheters and small enough implements to place. However, as you can imagine, this is a skill that has to be acquired, and it's not something that is trial and error. It's good that more and more people in our environment are beginning to go into this and getting the skill for it. Just a point on the sinovenous thrombosis. Prof mentioned it, just to emphasize that when we have trauma or infection, we should, think about this. As Prof was speaking, I remembered one patient who had ALL who was referred to the neurosurgery unit where I was doing my fellowship, and we were just observing. He seemed to have a bit of intracranial swelling, but he seemed to be stable, and then he just deteriorated suddenly in the night. Another point, the key diagnosis was that it was a sinovenous thrombosis. It was proven by imaging, and actually he ended up getting a combination of coagulation and intervention. Right, so this is a very important condition, and we have to keep it in mind. And again, it's a high index of suspicion that takes us to making such a diagnosis. The intracranial aneurysms, thank God they are not very common in the pediatric environment. But this is a case. This is a young girl, 15-year-old, who made me really think about, the link between the arteriopathy of sickle cell, the endothelial damage of sickle cell, and possible, aneurysmal dilatations and what to do about it. So she lives in Ho. She had collapsed, was being kept in a small hospital until somebody called. We saw the images. It was obviously a subarachnoid hemorrhage. Brain was very swollen. You can look at it, you can't see any CSF spaces. So at that point, we arranged for her to be transferred over. We did CT angio, and then we saw an aneurysm in the ICA terminus. If you look at the 3D carefully with an eye of faith, you might see, an aneurysm. It looks like somebody is trying to draw it out for me, right? But yes, so the blessing for this kid was the fact that we were like the next week or 2 weeks later, we're doing a mission for vascular treatment, and she got clipped, and she has remained, very well since then. But I think, especially for pediatric aneurysms, because we can't accuse most of these other risk factors of hypertension, and right, we have to think about a genetic etiology. And also, we have to think about, is there an impact that sickle cell has on the morphology of the blood vessel that will predispose to some of these things? And is it something we should look out for? And I'm happy that in some hospitals, the transcranial Doppler for following up these patients has become routine. I've seen it in UGMC, and I think, it's very encouraging, and how good a tool it is when it comes to monitoring these patients. Arteriovenous malformations actually bleed much more than aneurysms, right? And so usually, if we see a hemorrhagic bleed in a kid, it's more likely to be an arteriovenous malformation than, an aneurysm, right? And it's very common in children, and 80% of these children will present ruptured. And of course, this rupture, it's 10% risk to life and 50% post-episode morbidity, right? And the other thing about these patients is the fact that they have a 2 to 4% annual risk of rupture, which accumulates every year, right? So every year, another 2 to 4%, every year, another 2 to 4%. So the earlier we excise the AVM, the better. And so if, we neurosurgeons have a look at it and it's operable, it's better to, remove it and therefore take away the risk of rupture than to observe it and then end up with a huge, bleed. Just some thoughts on Moyamoya disease and the fact that I mentioned that it was a surgical disease. There are, very, very, well-studied ways to deal with it surgically. And, in our environment, maybe it's not as common as in other environments. But, whatever it is, it would be better to even do, selected bare holes for these patients than to just have, observation and aspirin. The direct revascularization is, more top heavy on skill because you have to actually suture a blood vessel, an external carotid artery blood vessel to an internal carotid artery blood vessel. And the key reason is to just bypass the narrowed area of the carotid so that you take, blood from the external carotid circulation and pump it into the internal carotid circulation above the area of stenosis. And this tends to reduce the ischemic environment. And we have seen very good results, both with direct vascularization, revascularization. Indirect revascularization is basically just taking the superficial temporal artery along with its its surrounding tissue, and then planting it directly on the brain, right? Whilst it is, still in continuity, right? So just planting it on the brain along with the little muscle, planting on the brain and then closing it. And that's the indirect revascularization. Whereas the bare hole method is just basically making multiple bare holes over the area of the stroking part of the brain. And what this does is to just basically generate some more perfusion in that area and reduce the ischemic events. So I think ultimately I've gone through most of what I wanted to say about the importance of neurosurgery. And I have 3 cases that I'd just like to go through. This is the first case, CT scan presented of somebody who had suddenly had an acute episode, right, of of a right-sided weakness. CT scan, not really indicative of anything significant. And then CT angio, you can see the hollow red arrow. You can see that at where the middle cerebral artery is bifurcating, there's nothing there, right? Okay, so at that point, the decision is made to do a thrombectomy, in which case you have a catheter passed into the carotid and go into that bifurcation, and then a stent is deployed and used to capture the clot, and then the clot is just brought out. And you can see the next picture, the C. You can see this is where a digital subtraction angio has been done after the thrombectomy, and the part of the middle cerebral that had not cannulated has recannulated, and you can see the perfusion coming back. And then the last is the MRI that shows the area of infarct that has happened after. But this is somebody who is going to end up being functional and discharged from the hospital. The second case, this is another patient in which, sudden ischemic episode, left-sided weakness. And the CT scan is done. The first CT scan is done. It seems innocent. And then it's followed up by a CT angio. And there you can see the gray-white matter on the right side disappearing, the interface disappearing. And then you do the CT angio, and there you have, that's a middle cerebral artery right at the terminus actually just disrupting. So you've lost basically a large area of middle cerebral artery. And in this case, you cannot do, it looks like the patient came late. So came outside the time frame for doing a thrombectomy. And so at this stage, a decompressive craniectomy is done. And you can see in the MRI how the brain has been allowed to swell, right? So in this patient too, this is a patient who would make it out, but, would have significant morbidity and would have to be supported through the rest of his or her life. The last case would be one where thrombectomy again comes in. The CT scan, this is a patient who has gone comatose suddenly, right? And CT scan is done, and you can see that at the green arrow, there's this, white signal, right? And this is just showing that a vessel is hyperdense, right? So the basilar artery is hyperdense, and then you do a CT angio, and then we realize that the hyperdense basilar artery, the basilar artery has completely disappeared. It's supposed to be one line in between the two carotids. So it's supposed to be in line with the hollow red arrow. It's completely disappeared. But in this case, again, thrombectomy comes in, so an endovascular approach is used. And then you can see in the L that the basilar artery is back because the clot has been taken away. And then this patient ends up with an infarct in the brain, in the midbrain, in the brain stem. But this is compatible with life, and this is a patient whom, without neurosurgical intervention with a thrombectomy, would not have made it out of hospital. So I think I'll just conclude here and say, pediatric strokes are relatively rare, but they're increasing in frequency. And generally, we need to come together with multi-skill, multi-specialty, ways of approaching to deal with this problem. It's not a problem that is going to leave us. It looks like it's a problem that is going to keep, increasing. And neurosurgery is an essential part of our strategy for the future. Thank you very much.
Thank you very, very much, Teddy. We've had a very densely packed information presentations, and I'm sure you're all learning a lot. We are running late. Please forgive us. But it took a while to get this panel together, so I want them to, fully give us all the information that they have. So we'll end with Kukwa, Miss Kukwa Garnett. Kukwa, please take over. She's going to do neurocognitive assessments in pediatric strokes. After that, please put your questions in the chat box. We'll answer questions after Kukwa. And also the link for CPD points is in the chat box, so you can fill this. Thank you very much. Kukwa, are you there? Okay.
Yes, can you see my slides?
Yes, we can see it if you put them on slideshow.
Is it better?
Yes, please. Thank you.
Okay. Hello again, everyone, and thanks for your time this evening. I'm recovering from a very bad cough, so please, please bear with me. Today I'll be speaking on neurocognitive testing in children who have had stroke. As we would have heard in the previous presentations, pediatric stroke is not rare at all in Ghana. We see it in congenital heart diseases, we see it in children with infections like meningitis, and of course, sickle cell disease, as was mentioned earlier. But after this, okay, that's done now. But after the children have been discharged and after they've survived the stroke, everyone is happy. They go back to school, friends and family are so elated that sometimes what we do not notice is the hidden difficulties they face. So the hidden difficulties are in their memories or attention, etc. We do not notice these changes or these difficulties they face until much later. And it's this much later we are trying to avoid. And that is where neurocognitive testing comes in. And so what's neurocognitive testing? Neurocognitive testing or neuropsychological testing, as we use interchangeably, are structured assessments that we use to evaluate cognitive abilities. So in pediatric strokes, neurocognitive testing is used to assess the impact of the stroke on the child's cognitive abilities. So what we want to find out is we want to know if these areas are functioning optimally or suboptimally after the stroke. So we have what we usually would assess language, both expressive and receptive language, intellectual functioning, academic achievement. We assess processing speed as well, memory, visual motor skills, and what is usually overlooked, behavior and emotion. We assess those. But then when and why do we test? Uh, for stroke, as we have heard, it's a very critical and crucial um, uh, stroke is very critical and crucial. So testing as well, even post-stroke, becomes very important. Um, and it's important to test timely as well because neurodevelopmental needs of children differ, plasticity as well, and then brain recovery all affect what is assessed. So then in the first couple of weeks post-stroke, the 0 to 2 weeks, a child may be sedated, the child may be in the ICU or simply just too medically fragile to do anything. So at this point, let's call it acute recovery. At this point, cognitive profile really is may not be reliable. So what you could do at this phase, or what we do at this acute recovery phase within the 0 to 2 weeks, is observe. So you'd usually observe what is happening. So you observe alertness, you observe any communication, verbal or not, the child can make. And as you are observing as well, you could ask for school reports to form some baseline, and then parent history as well. So you can talk to parents about how the child was before to form your own baseline as the child is sort of getting out of the acute phase. And within 2 to 8 weeks, you could do a brief cognitive screening. And this one, we're saying brief cognitive screening because you could do it by the bed. So let's say bedside assessments. You are able to identify any severe language impairment, attention, or orientation here. And you don't necessarily have to, you may not necessarily have to carry the big neuropsych batteries along. The tools can be adapted for this bedside purposes. So for instance, you can have verbal recall tasks where you can say some words to the child as a child to say back to you. You can have the child draw some tasks for you, digit span, say some numbers, repeat, and all of that within the 2 to 8 weeks. And then from 2 to 6 months post-stroke, this is where you want to do a formal neuropsych eval, where you want to schedule one, like a very formal one. And the hope is that by this early recovery phase, the brain swellings and any acute changes may have resolved. If I'm wrong, but that's the hope for us that by this stage, most of these things would have resolved and the child could sit longer and give more valid results. So at this time, we'll be testing memory, attention, executive functioning, more language, and motor speed as well. And for the 6 to 12 months and beyond, the goal here will be to monitor long-term recovery. And so there's the when we test and the why we test. One of the reasons we test is to be able to guide school support. So after stroke, the child is discharged, hospital says everything is fine, but then the child goes to school and you could tell that the child has changed, but then that's all everyone is saying. Oh, Kofi as a son or Kofi has changed something. And so neurocognitive testing after beyond 12 months is to guide school support and detect any new challenges that may occur. And also because academic demands increases. So what a child will be learning in KG1 or KG2, should a child go to class 1, the demands will increase. And so with the neurocognitive testing, you are able to plan and detect some of these new challenges. And beyond the 12 months to we encourage reassessment, um, especially when transitioning from one class to the other, so that you're able to see what the challenges are and what the improvements have been. And also, whenever there's a new learning challenge, whenever any new learning challenge emerges, it's also ideal um, to test to see. And yeah, so these are the time periods that are crucial for testing, and also why we test to identify the deficits early if there are, and then it also helps to tailor interventions. So now we know that, oh, it's language, it's memory, it's attention, and then we're able to tailor interventions. And also it serves you're able to make a checklist to track your changes, whether or not the child is doing better after a year or not doing better. So what happens in testing? So within the 2 to 6 months where the formal neuropsych eval is scheduled, the child would typically come to the clinic if possible. And the length of the testing usually varies, but then it's typically between 3 to 6 hours. But then they don't sit for the whole period. Um, they take a lot of breaks. And also well, I can speak for Mission Pediatrics. For Mission Pediatrics, we would sometimes do 1 hour sessions over 2 or 3 or 4 days. We don't, if the child is uncomfortable, the child is uncomfortable. We don't have the child do everything in a sitting just because we want to kill the time. So that's what happens. And so the child comes in, and then there's a checklist of the domains we are checking. Sometimes you are lucky and the parents will say, oh, after the stroke, maybe language, maybe receptive, or maybe expressive, or um there's one thing they usually would say that, oh, in Tree, I hope everybody can speak Tree, but why you slow? So then when they start saying things like that, at least you have an idea where they are going to. But then these are the domains we check. We check intellectual functioning, language, memory, executive functioning, visual motor skills. There are other domains as well. For Mission Pediatrics, we have the very best and expensive neuropsych test paid for Pearson tests, and we have all these ones that I have over here. However, for copyright reasons, I'm not able to show you what they look like, because if I show you, you can print it out and administer as well. But you have to pay for it to get access to it. So for copyright purposes, I can't show you the KBC, the KT, the BASC brief. I can't show you any of them, but um, they are for academic achievements, assessing academic achievements, language, memory, executive functioning, and visual motor skills in children. What I can show you, however, these ones, you can find them online. So there's an example of a test that could be done post-stroke by the bedside. So this one assesses processing speed, the making test. So all the child has to do, you give the child a pencil, and all the child has to do is to match 1 to 2 to 3, 4 to the last number, and it's timed as well, and to measure processing speed. This one is trail making test B. It also assesses attention and working memory as well. This one, the child moves 1 to A to 2, 2 to B, like that, and it requires a lot more reasoning into it. So it's able to assess working memory and attention as well. This one is the grooved pegboard. It assesses visual motor skills, so you can use it by the bedside within the 2 to 8 weeks post-stroke, to check hand-eye coordination. The child picks the pegs and puts them in the holes with the left hand, and then does the same with the right hand, and yeah, timing as well. Okay, this for executive functioning as well. For a bedside test, you can use the Stroop color test, and for this one, if you look at the second line, for instance, it reads red, purple, blue, orange, and green. But then I say to the child, don't read what is spelled, read the color. So tell me what the color is, not what is written. So instead of red, you are telling me blue, green, red, and it requires a lot of decision making and you remembering the instruction I gave you and all that. So we're able to measure executive functioning with this one. So with some of the bedside test, you can do some of these ones quickly so that you don't stress the child too much. You don't stress the child too much. And as I mentioned, because of copyright reasons, I'm not able to show you some of the Pearson ones that we use at Mission Pediatrics. However, you can Google it and have, you won't see the content, but you could still Google it and have an idea what it is. KABC, KT, waist, whisk, Basque brief, all of them. The testing for executive functioning and processing speed and all of that. Oh, I didn't realize I went through that fast. Okay, so some limitations with the testing in Ghana. First one is the culture. So first and foremost, a child having a stroke alone, there are some parents who would say that the stroke itself is some mommy water thing. So then an additional community test, neurocognitive testing does not sit well with them. They won't even listen to you. But we're getting there. More and more people are welcoming neurocognitive testing in Ghana, so it's getting better. The second one is the limitation is the culturally relevant test items. So most of these test items are not, or all, let me say all, are not developed here in Ghana. So first and foremost, they're in English. So you have a child coming all the way from Wenchi to do testing, and you are giving a child something to read. Which one of them should I show? You give a child something to read, and the child is unable to read not because there's an issue, but because the English is just too difficult. If you showed the child something else, it would have been better. So that's one challenge we have, that the tests are not developed here, and so they are not culturally appropriate for our use, especially when the children do not school in Accra or English is not their first language. And so the third limitation is access to pediatric trained neuropsychologists. Now there are more more psychologists compared to before. However, access is a problem. Again, I'm going to use an example with the Wenchi. And I don't know any of my colleagues who want to go and live in Wenchi. So, and so you still have the psychologists being in Accra, and then those in far off places do not have access to them. And even with those of us in Accra, access to tools are a problem. For me, at Mission Pediatrics, access to tools is no problem for me because we have the tools. But in other places like Lekma, you wouldn't get the updated versions as we have. So then that's also another challenge. And then proximity to facility. I've had very few in past couple of months. I've had clients who have had to travel from far other regions to come, and because of that, they come one time and they're not able to follow up with the with the testing to complete. And then there's the issue with finances, as there is everywhere. And then there's testing fatigue. Sometimes some of them feel like it's too long, and then they go and then they come the next time and they don't want to come again. So if we could develop suitable tests for us and shorter, but shorter also does not mean better, but then that's another limitation. And then the follow-up gaps, because of proximity, because of finances, some would come and not come again, or come after a month or 3 months, and it doesn't really help with the rehabilitation. So then how do we encourage neurocognitive testing in Ghana? Um, Dr. Teddy said something about the multidisciplinary approach, which I also ascribe to. So if we, at the point of being discharged, or even, yeah, okay, at the point of being diagnosed, okay, you had a stroke and we've done this, we've done this, we've done this. I think there should be more integrated um uh, care. So then the Dr. Teddy says to you that, oh, this is what you have. And then this is our psychologist who will be doing this, instead of having to refer to you, and then the parents now have to go and find a place where they can do the testing, if it's all integrated at the point of diagnosis and treatment and discharge. And so they know that from here to here to here, from here they're going here, and you are included in it. I think that would be better. And then the integration as well, school integration. So we have the schools involved in the in the planning. And this because when children post-stroke, children go to school. That's the only place they'll go to. They're not adults to go to work. So then it means school is important. So then the schools have to be involved in the care and everything. That's why we have the after the testing, we have school support where we give the children IEPs for school, how the school can help them and all of that. And then encouraging long-term rehab. Currently in Ghana, because of finances and because of proximity and all of that, you don't get long-term rehab. People will come for the rehabilitation, and you tell someone to come for reassessment maybe in 6 months or even a year or two. They're not able to follow up. They're not able to come. But then we need to know progress, because sometimes things are difficult. Things may be easy, but then as you go, maybe JHS, high school, things get difficult. But then because you didn't come for the testing, now there's a break, and we don't know at what point there was a break and where we are helping you from. So then long-term rehabilitation is also important. And of course, the collaboration, as Dr. Teddy said, between neurology, neuropsych, education, and therapy. Sorry, and therapy. So to wrap up, I'll say stroke in children doesn't end at survival. the it, they are discharged fine, but then it doesn't end because they survived a stroke. Most significant challenges, especially the learning difficulties, emerge after the hospital discharge. And neurocognitive testing helps us to see the invisible effects of pediatric strokes. And although there may not be testing available, maybe in a village or in remote areas, PORDs, parents observations, and some quick cognitive checklists can make a very big difference. Thank you very much.
Thank you very much, Miss Kukwa. I don't know, Kukwa, do you have anything against Wenchi that he kept talking
Dr.
about?
Mamal, I had Wenchi today and I said I must use it.
Okay. So we are ready to take questions now. I know we've gone past our time, about 15 minutes past our time. I will first look at the questions in the chat box and see. Lots of appreciation for our panelists. Awesome presentation. Thank you. Insightful presentation, powerful presentation. So we thank you so much, Prof. Kathy, Dr. Teddy, and Kukwa for giving us all this information. I believe we've all learned quite a bit. There was a first question about the causes of strokes, but that was asked before the presentations started, and I believe that has been answered, so we will not go over that. Stephen Asante, your hand is raised. I think you can ask your question. Host, can you unmute for Stephen to ask his question?
All right, thank you very much for the presentation. Please, my question goes to Prof. Catherine. I want to know, at what point do you have to recheck the HB level after the blood transfusion in terms of hours?
Okay. Marilyn, can I go ahead?
Yes, please.
All right. I'm going to thank you, Stephen, for that question. Let me link it to a question I've seen in the chat from Iceland, which is about what HB do you aim for? Is it the steady state or is it the 10 to 11 grams? So just to say that in the context of transfusing for acute stroke or transfusing for an acute exacerbation of anemia, the goal in this case is to reduce the S to less than 30%, because what you're trying to do is to break that cycle of events that's causing that pathophysiology. So your primary outcome, so to speak, is the less than 30% S. But in doing that, you want to ensure that your HB doesn't go beyond 10, which can very easily happen if you're just doing simple transfusions. So you're not aiming so much for a specific, your goal is the drop in the S percentage, but you're doing this without increasing the HB beyond 10 to 11. So for every transfusion, so in this case, in the case I presented, for instance, after the first transfusion, this child should have had testing, full blood count to see where the HB is, and also a test to see what the percentage of S is. Previously, it was HPLC, very expensive, that had to be done, but now we have point of care tests that can give you the S percentage, very, very easily done at the bedside. So Iceland, the goal is really that drop in S, but at the same time, not increasing your HB beyond 10. And if you haven't achieved that drop in S, but the HB has reached 10, then you need to do an exchange transfusion. Now, this is in the context of transfusion where you're increasing the HB quickly, because the viscosity, the rate at which the HB rises is a risk factor in terms of increasing viscosity. This does not count in the context of somebody on hydroxyurea where the HB goes up gradually, but also HU actually reduces viscosity because of the effects it has on the blood and all of that. I mean, that's a whole completely different presentation. So here we're speaking specifically about acute transfusion increasing HB rapidly. Now to Stephen's question, when do you check the HB? Really, you can check the HB within hours of the transfusion. So we've been sort of conditioned to wait for 24 hours, wait for 48 hours before you check. But there's actually no evidence for that. And within a few hours of the transfusion, you can check the HB. When we're doing exchange transfusions, we usually will do it right after. So you do it and we take a post-transfusion immediately after the transfusion. Thank you.
Thank you very much, Prof. Kukwa, there's a question for you that says that after the neurocognitive testing, then what is the next step after neurocognitive testing?
Thank you. After neurocognitive testing is rehabilitation. So then the testing helps you to know which areas have been affected and the in with the testing as well, you get help with what to do next. So if it's language, how are we improving the language? It doesn't happen overnight. It's not like medication. So it takes a period. It can take 3, 6, a year. And so we help you through that rehabilitation process. If not us, we refer you to speech therapist or OT. So that's what happens after the testing.
Thank you. Thank you. There's another question to Prof about the TCD. Somebody is asking if it can be used up to 18 years.
Okay, thank you very much. So TCD as a modality can actually be done at any age, and it's done for different reasons. So as Dr. Totime mentioned, in adult neurology, neurosurgery, TCD is even used to sort of like monitor patients who've had bleeds and so on. In the context of sickle cell disease, the cutoff age for routine screening is 16, and there are a couple of reasons for that. The first is that it can be very difficult to get a good acoustic window in older children because you need to be able to find a good window to read the velocities accurately. So the older the child is, the more difficult it is to get that good window. And secondly, as children with sickle cell disease become older, there is a shift in terms of the type of stroke that occurs. So in the young adults, it tends to be more hemorrhagic than ischemic stroke. And TCD in this context, you're using those velocities to predict ischemic stroke. So the evidence hasn't shown that there's much benefit to doing routine screening beyond the age of 16 at this point in time. So we end at 16 years for routine TCD. Thank you.
Thank you very much. Thank you very much. There's an evaluation form in the chat box. Kindly evaluate this program so that we know how to tweak our programs to give you better education through these CPDs we do for PSG. So please make sure you evaluate it before you leave. Since there are no more questions, if NEC has any announcements, Genevieve, kindly take over for announcements.
Hello, good evening.
Good evening.
Please, no announcement from NEC. Just to say thank you to our resource persons for an excellent presentation and to Dr. Marilyn yourself for moderating the session. Thank you.
Thank you. Thank you very much. I'm also going to say a big thank you for all of you participants who were able to join us. I think we went up to 350 on a Sunday when people are chilling. We do appreciate your time, your precious time for joining us for this CPD. My closing remarks would be that definitely for our tertiary and quaternary centers, I think we need to have stroke teams. I'm not sure if we have pediatric stroke teams. I know the adults do have it, and so if we do not, it will be very important to start thinking about having our stroke teams in our tertiary, quaternary, and even the secondary centers before we refer them. And if the teams can have multidisciplinary integration of care, I think that would be really excellent. I know there's a psychology department in Kolebu, so definitely that can happen. Neurosurgery, psychology, social work, plus the neurologist and the hematologist. That would be a powerful team to look at for strokes for the tertiary and the quaternary centers. I also want to say a big thank you to those who joined us. I saw some adult neurologists on the call, some neurosurgeons, some adult physicians, public health physicians, and some of my parents even joined, and some of the teachers. So thank you so much for all of you joining. And I hope that now that we've learned a lot about pediatric strokes, we will start talking about it. For the last meeting we had, we were tasked to start putting down protocols for us in Ghana, how we handle our pediatric stroke, so that no matter where you are in Ghana, you know what to do. I shall be calling on some of you to join a team so that we can put something together. Thank you very much and have a good evening. Bye, everyone. Please make sure you fill the evaluation form before you leave. Somebody is asking for the slides. The slides are going to be on the YouTube page for Pediatric Society of Ghana. So the whole presentation and the recording will be there, so you can have access to that. Thank you.